In this week's podcast, we have Dr. Mike Macias, Community EM Director Extraordinaire. I have learned so much from Dr. Macias with regards to how to do community ultrasound in the emergency department. Now, it's really the same stuff. It's just maybe we have a little less time. I actually had a lot of insight because truthfully, when we're working together, we're working kind of parallel. I'm not presenting patients to him and vice versa. So it's nice to actually be able to chat with him with regards to management and what he thinks. And the thing that was most interesting to me was that he really thinks that using ultrasound during the resuscitation of a critically ill patient is very much a community thing because we don't have everything and we have this easy bedside tool. We should use it, which is a bit of a paradigm shift for me. Don't get me wrong. Almost always use ultrasound, but I try to think about what would someone who wasn't basically into ultrasound from day one, from literally intern year of residency, what would be applicable to that person? And Mike thinks that resuscitative ultrasound is probably the most important thing. Totally agree with him. We also talk about a study that we did here in California in Temecula, where we work, and a bunch of other institutions, where we actually looked at data from community-based practices. There's thousands of patients, a bunch of providers, and we found some interesting data, which I think that you'll find interesting. So stay tuned, check it out. Dr. Mike Macias. Hello, my name is Jalen Avila of the Ultrasound Podcast, and I'm very happy to have a third time, I guess technically it's the second time, but it's like the third episode where I get to sit down with community/academic hybrid ultrasound extraordinaire, Dr. Michael Macias. Mike, how are you?
I'm doing good. How are you?
I'm doing great. I'm a little bit bummed out that we couldn't meet in person the second time around. But this just worked better with our schedules. I have to go into work. And also it was a little windy in your in the backyard. So maybe this is
hmm
like a little bit easier for like hair in my face and stuff like that.
hmm
But I'm
hmm
happy to see you and happy to get some more of your knowledge recorded for the internet. So it's there for all times, essentially making you immortal.
Well, thanks again so much. I love these opportunities to chat about ultrasound, specifically talking with you. You have an immense amount of expertise, and I love just kind of the back and forth and really hoping to spread some point of care ultrasound knowledge. So let's do this.
You are so kind. All right, let's get right into it. I had a few more questions that I think that optimistic me really thought that we were going to be able to like get through on our first session, but I'm happy that we have this session. So, getting right into it, what do you think is the most common application overall in the community setting, in emergency departments, of course?
hmm Yeah, absolutely. And I think this is prime time to talk about this question because, as you know, me and you just did a study really trying to answer this question. I think part of the frustration for the community has been, what is the status quo for community point of care ultrasound? We have a lot of studies that are academic centers, have residents, right? That knowledge base and evidence-based understanding is there, but we're still a little bit behind in the community in trying to transition all of that knowledge and research we have into clinical applications that community doctors are using. And so we decided to look at that. We looked at 22 hospitals that are community-based hospitals around California, using some of our group billing data. And we investigated over 4 years of data, over 27,000 ultrasounds to really see what is being done in the community. And interestingly enough, we found that cardiac and abdominal imaging are really the most frequently used. One of the issues with our study was we used billing code. So we were only able to see cardiac and abdominal as a billing code, and we couldn't really tell, is that cardiac ultrasound being used for a fast exam, right? Or is it being used as a true cardiac exam to assess for maybe LV dysfunction? But in general, those were by far the most used. So they represented a significant portion of exams. And I feel like that fits with my practice and what I've seen at my site. I really see people still using it for fast. That's still a common application. But then the cardiac ultrasound really has become a cornerstone for a lot of doctors, looking at bedside assessment of LV function, looking to see if there's a pericardial fusion. Those are common applications that it's used for. The other big one was procedural guidance. And I think that's been sort of a standard now, especially with knowing that it's safer to use ultrasound. So vascular access, procedural guidance for paracentesis, thoracentesis, that was a really common application. And then surprisingly, on the opposite side, which was a little shocking to us, was we found that pregnancy, ultrasound for pregnancy, usually first trimester, renal, aorta, and ocular ultrasound were surprisingly low. I think out of those 27,000 exams, they really only represented a few percentage points each. So that was
not
sort
even
of
1%
a shock to us.
or like a couple of percent.
A couple percent. Each one was about 2% of the entire amount of studies. So really low utilization of some of those applications. So still a heavy focus on the fast cardiac there, got procedural guidance, but I think we have a lot of room to sort of increase these high yield exams that are not really being done that much in the community. So kind of surprising, and I think helped us identify some targets that we need to work on from an educational, cultural standpoint in the community.
So I think we kind of like glossed over the initial like derivation of the study, or like how it like happened. And this has recently been submitted. It is early January of 2024. And I think, have we already like submitted, or is it like in the process of being submitted?
Yeah, so interestingly, we just finished collecting the data and doing the statistics, and it has been submitted. So right now, it's not really available publicly, but hopefully, fingers crossed, we get accepted and start disseminating that research to the community to help kind of everyone to address what are these areas of deficiencies, what we're doing right, and start moving forward.
Brilliant. One of the things that I really like about the study, and this is something that we're working on with one of our second year, going to start third year residents, Taylor Fernberg. What I like about it is that a lot of the kind of community-based or even like the academic-based studies look at Medicare data, right? And that's good, but it doesn't capture, I think, as much as you look at something internally that is being billed, because it's not just Medicare patients. It's Medicare patients as well as it's just anything that was billed basically was like included in this study. And we use, it was 22 sites, right, Mike?
Mm-hmm.
And we used like the same middleware for ultrasound for all of the sites. So that's why, right? That's why we were able to like actually grab all this data. And it was a lot to go through. And I think I did find one, and I'll post it in the show notes. But I found one that was also a community-based one that had a large population. And I'm happy to have all data out there because I think all data is useful. But I think that ours is a slightly higher patient population than the one that was just published, also from a hybrid community academic program. So we're starting to basically like fill the data outside of pure academic centers. And I think it's quite important. Now, what do you think for like our group specifically? What do you think is the barrier between, let's just pick one, a pregnancy ultrasound, right? OB ultrasounds. I mean, that's something that, I personally see a lot of first trimester pregnancies. So we're seeing first trimester. We're not really seeing second and third where we're at because we don't have OB in-house. But what do you think the barrier is?
I think there's a couple. That's always been one of those about like, at least if you're ultrasound trained, like why can't we get people to do more just bedside pregnancy ultrasound? We know, right? The data is there. Sorry, I'm going off on a little tangent, right?
No, I'm asking you this specifically.
Faster time to getting ectopics to the OR, right? We don't want those patients sitting and waiting for comprehensive ultrasounds. Faster time to talking to OB, decreased length of stay for just confirming IUPs. Emergency physicians can do this. We know that it's safe. So there's so many studies. I'm just naming a couple conclusions that we've seen. but we just can't get them to do it. And I think it's twofold. I think there's a little concern about liability. I think that's been a thing in the community, and that's why you've seen a lot of studies trying to answer that question. There's probably 3 or 4 studies that fairly recent that have looked at, are emergency physicians getting sued for, using point of care ultrasound, and no one has really been able to show that. In fact, there's been sort of some data that suggests that they are being sued if they don't use it. There was a couple cases of a fast that was missed. Basically a patient didn't have a fast exam and went home and ended up having internal bleeding. So I think liability is a fear. I think it's not necessarily a true fear, but I get it, right? Anytime there's something different that we're used to and we're taking on more responsibility, if you don't feel that you're proficient in that specific skill, right? That plus some like increased liability might make you not want to do it. I think that that's a big driver. I think the second driver is flow. Coming now, we work together, right? Is people feel like they got to keep saying thanks, seeing patients, and they feel like doing an exam is going to slow them down. We haven't really seen that borne out. I think, again, that's one of those like perceived barriers. I looked at people that do a lot of ultrasound versus people that don't, and I looked at their charges per hour and the amount of patients they see, and they weren't any different. So I've been actually trying to use real data to show people that
it doesn't slow us down.
The concerns they have are not true, but it's really hard, right? It's still hard to change people's minds. And so that's why for me, it's been a progressive change. And I think the more education we do, the more case-based examples, the more buy-in we'll get. And then there's just going to be a group of physicians that are going to keep practicing their way, and that's what they're comfortable with, and that's okay too. So I think that's sort of answers that pregnancy ultrasound, but also kind of point of care ultrasound incorporation as a whole in the community.
Yeah, I think, and I try to think about this as well, because I like to assume that everybody like wants to do their best, right? Like, I don't think anybody on purpose is trying to do a bad job. And I'm wondering if some of it is that we're, unfortunately, especially in like kind of peak times, we're seeing, sometimes we're seeing patients in the MSC rooms and we might not be able to do it. But we also, there's always like ways that you can do it. And I try to teach the residents this, and that's that, yeah, it might seem like there's a, like it's going to take longer right now. But if you like actually look at the whole course in the ER, with us having them go to radiology, having them come back, wait for the read to be done and everything, it's going to be shorter if you spend that extra, we'll say 5 minutes on the high end, doing the exam and getting that fetal heart rate, confirming that IUP. And I think part of doing that, getting people to do that, is us chatting about it and showing data, like the data that you're collecting right now that shows that it doesn't really slow you down at all, at least not to an appreciable degree, not inferior in any case.
Yeah, I think you hit the nail on the head for sure there. It's the activation energy, we know that it's going to save time in the long run, right? You're going to get that patient out faster, but you're like, man, that's going to take a few extra minutes of my time initially. And it's hard to like, we're not good at gauging like now time versus later on time. It's hard, time estimates. So it's like, you have to sort of get over that activation. So yeah, it's going to take me a few more minutes now, but I'm going to get that time up on the end. I'm going to be dispoing my patient faster, right? And now I can see another patient. I could decompress that ER, that waiting room, faster than I would without it. So it's just that kind of gap in like the doing it now versus later sort of thing, and trying to understand that time differences.
I'm going to take a quick pause here and remind you about the Ultrasound Leadership Academy. That is ultrasoundleadershipacademy.com, where we have a full year-long curriculum. Image review, one-on-one hangouts is basically an online ultrasound fellowship. Check it out at ultrasoundleadershipacademy.com. Now, back to the podcast. I wonder too, like with Ocular, because Ocular is something that I end up doing a bunch because I can't like look in, I can't look in the back of the eye. It's all pinpoint. We don't use pupillary dilators.
I mean, I don't really know any ER that uses it all the time as far as like ER doctors go. And it still seems a bit inefficient to like try and like get in there and like be right on their face and kind of do all that stuff. Whereas you can do it with the ultrasound and be pretty accurate. What do you think the barrier is with ocular ultrasound specifically?
Yeah. Well, again, this one's definitely going to be probably a little biased, my interpretation of this. Even though ocular is low, I still do think I'm seeing increased utilization of ocular compared to pregnancy. And one, I think that probably ocular complaints, or at least indications for ocular ultrasound, are probably lower than all of the pregnancy-related issues we see in the ER. So that would be interesting if we looked at volume of types of presentations to see kind of like what the percentage of ultrasounds performed related to a specific complaint. For example, the percent of ocular compared to the amount of ocular cases we see, and the pregnancy cases compared to the amount of pregnancy cases we see. Do you see what I'm saying?
Yeah,
To
that'd be
sort of
like really cool to see.
create a baseline, because I do think that even though ocular is not used as much, we only had a couple percent. I think ocular cases are seen less. So I felt like I have seen more usage because the eyeball on ultrasound looks like the eyeball, you saw from your anatomy book.
Yep.
So I honestly, just from working with docs that haven't used ultrasound as much, feel like they find it a little more approachable because it's, you know what I mean? It's an image that you're familiar with seeing. Like, the shape of the globe, where the retina is, and it doesn't take a lot of like pattern. It doesn't take too much education.
Yeah. Or
barriers, though,
imagination, because like sometimes like there's certain things that you have to just kind of like imagine. You're not used to seeing the anatomy, but the eyeball looks like, if you have a transverse, it looks like an eyeball in transverse. That's exactly
looks
what
like an eyeball.
Yeah.
I am going to go back to the barrier again, though, with the liability. It's the same thing, and I think that's the same space. Is if someone has a complaint and it sounds like a concerning history, saying there's no, for example, retinal detachment is the big one, right?
Mm-hmm.
Saying that and being that bottom line, if you're concerned, is certainly taking on a little more risk onto the ER physician's shoulders. Again, I don't know if I'm born out in the literature if that's true that they're at increased risk, but it feels like that. So if you're in the community and you were previously thinking about transferring a patient, and now you say there's no retinal detachment on ultrasound, like, how does that differ in their mind? Like, do they feel comfortable with that? So again, I think a lot of it in the community comes down to the risk shifting. And certainly I'm sure there's been survey data on that's confirmed that. But I think that's a portion of it. And I don't know what your thoughts are on, at least from what you've seen, but that would be my thought for ocular ultrasound as well.
Yeah, I mean, I agree with you as far as that being a potential barrier for sure. I think for me, the big thing is that really, when we kind of boil it down, I think of it as like, and we're talking pure ocular, right? I'm not talking about a central retinal artery occlusion. I'm talking about a pure ocular problem. If the patient has vision loss and I don't see a retinal detachment on ultrasound, the likelihood is very low, right? If the patient has blurry vision, at that point, I'm like, like the likelihood of it being a true retinal detachment is pretty low. Honestly, apart from the ultrasound, like I almost use the ultrasound in patients with suspected vision loss or complaints of vision loss as a confirmatory, like a rule in rather than a rule out thing for the most part. But if they have blurry vision and that's it, I mean, things always can progress, right? I mean, the natural course of a non-traumatic retinal detachment, it's a regmatogenous, which means tear in Greek or something. It's as we get older, right? And I'm not telling you anything that you don't know, but as we get older, the vitreous kind of comes off of the retina. And that's normal, actually. It's completely normal. I mean, I would argue that the majority of our patients above the age of, let's say, 70, are going to have at least a small retinal detachment. It's quite normal. Almost like BPH with elderly gentlemen, right? Or patients with prostates. It's very likely to be enlarged as they get older. It's a normal course of things. Almost everybody with age has the vitreous come off. A small percentage, there'll be an abnormal like adhesion, and it'll kind of like come off with it, to like pull off. And then a smaller percentage of that, let's say, the retina kind of tears a little bit, fluid will get in between and actually push the retina off, right? So you might have a patient that has some blurry vision because of a vitreous detachment, has a little protein and stuff in between the vitreous and the retina. But if it's just blurry vision, right now, it's not a retinal detachment. Now, that doesn't mean that it's not going to progress, but right now there is no retinal detachment, right? The other big thing that I use it for is in patients where I see a retinal detachment, it's actually helpful to have clear kind of like indicators if it's macula on versus macula off. If it's macula on, it's actually more of an emergency, right? Because their central vision is still being spared, which you can identify that just based off of where the tear is in relation to the, medial versus lateral and the optic nerve. Versus if it's MAC off, they've already lost central vision at that point. So it's less of an emergency, although I would still transfer. So I think to answer your question, very long-winded way to say that I clinically correlate based off of vision loss versus no.
And that's the thing. It's all of these are clinical correlations, right? Yeah. And we're not just using the ultrasound in the black box. If you're still concerned about it and your ultrasound's not answering your question, right, you still got to do what you got to do. And for example, if you sudden vision loss and your no retinal detachment, then your workup's changing, right? Your diagnosis is changing. You talked about cryo, and which ultrasound can work for that too. But yeah, so clinical correlation is so important. And maybe honestly thinking about it, that's some of the issue, is that clinical integration aspect of education. Is learning is focusing not only on how we're doing these applications, but if we don't have that clinical integration piece, that could also be a barrier. Like, what do I do with this or X, Y, or Z on my ultrasound finding?
Yeah, exactly. Now, besides those two that we mentioned, OB and Ocular, what is another big missed opportunity, do you think, with community docs as far as ultrasound applications?
I think, well, first, pregnancy ultrasound, I think we have room to improve. Same with Ocular. But I think one of the big things that I've been really trying to push, and this is as I've been diving into a lot of the cognitive biases we have as emergency physicians, helping us not miss things, and how do we use ultrasound effectively. And I think one of the big groups that comes up is the immediately critical undifferentiated patient. As emergency physicians, right, we pride ourselves on we are adaptable. We get sick patients. We don't have any information, and we have to manage these patients. And before ultrasound, right, there was not as much information you could gather. And a lot of physicians trained, using their physical exam and their vitals, obviously the way the patient looks, all of their experience to help determine, right, what's my next step? Do I need to do a procedure? Do I need fluids? Do I need vasopressors? And I think this is really where we need to bring ultrasound in the community, focused on things that we can actually make big impacts. So I think the undifferentiated hypotensive patient is really where I've shifted to my focus on is how do we make sure the community doc knows if I have a hypotensive patient come in or ill-looking patient, maybe they're not hypotensive, they're just working hard. How can I use ultrasound to quickly identify what's going on and figure out my next step? Right? Maybe it's the critical breather. I can quickly look at the lungs and the heart and see, is this flash pulmonary edema or severe COPD? Or I have that crushing chest pain with a non-diagnostic EKG. Is this a dissection or is there a wall motion abnormality and they're having a STEMI? Or if they're just hypotensive, what does their heart function look like? Is there fluid around the heart? Is there signs of a big PE? What's the IVC look like? Are they bleeding internally, right? All these things we can answer really, really quick. And I think that a lot of these things in critical patients, it's more obvious. You've probably seen a lot of data on that. The more sick a person is, the better point-of-care ultrasound performs, right? It's not really good at picking up subtle pathology. But if someone's really sick, like for example, if they have a massive pulmonary embolism, you're going to see that RV is very abnormal. If it's a little tiny one, right, you're not going to figure it out. So it makes it easier actually to do ultrasound in critically ill patients because one, you kind of know what you're looking for, and two, the findings are usually more prominent. So that's kind of, I think, a missed opportunity that we have a lot of room to grow.
That's a really good idea. I mean, initially when you say like critically ill patients, I'm like, I don't know, maybe that's not like a great for a community doc. We see critically ill patients all the time, right? And so to be able to quickly figure out what's going on without any lab test, after the physical exam, I think you're right. I mean, we should be doing more of it in the community. What mnemonic do you use? Do you use the high map or do you use the pump, tank, and pipes mnemonic? Which one's your favorite?
I'm a high map. I think it's
Same.
just easy for me to remember. As soon as I say it, all of the all the spots I have to look just light up. So I've always been high map. It's just really easy to work through it. And just helps me structurally make sure I'm doing everything. Because sometimes, I might slack and not want to do one aspect because I'm like, oh yeah, it's probably not that. For example, like aorta. But if I follow my algorithmic approach all the time, I make sure I'm hitting it, or at least, do a quick aorta sweep, just to make sure. So high map, all the way. How about you?
I'm the same. And also, like, I think it's also in the order that I think is the most important. So, heart, I think, is like the most important thing to look at first off. And then IVC kind of like helps to me to like categorize. So it's HIMAP. The IVC kind of helps me categorize it. Is it like a distributive hypovolemic or is it an obstructive type shock, right? And then M for Morrison's pouch, that's the FAST exam. The person who came up with that mnemonic, the Rush exam, the rapid ultrasound in shock and hypotension, two different people came up with the same concept similarly. The Scott Weingart version, which is the high map, you talk to him about it, and I've actually been on his podcast to talk about it. He just does a right upper quadrant view. He doesn't do pelvis in left upper quadrant because in his mind, which I agree with, a patient's not going to be hemodynamically stable with isolated free fluid in the left upper quadrant. So he just looks in the right upper quadrant because that's the most common place for it to, be positive, especially if it's a larger amount. And then aorta for AAAs or dissections, and then pulmonary is, usually, honestly, it's just pneumothorax because a pneumothorax is not a pleural effusion is unlikely to cause hemodynamic instability just because you can't really, like lose that much like blood in the chest by itself, although you could have a tension hydrothorax as well. Pneumonia doesn't really by itself cause a shock, although if you have septic shock, it can. So that can kind of like help. But also IVC would also be helpful. You see low volumes before you even like continue on with the Rush exam. You can go ahead and start giving fluids, right? Or start giving blood if they happen to have obvious signs of external bleeding. So that works the best for me, and I use it as well. I'll be honest. Once I find a positive, I don't always go like all the way down. Like if I have a patient and I see a big right heart, I might not go and look for the dissection, right? Because like, most of the time, if we see a critically ill patient with an enlarged right heart, we're thinking PE, right? Although if I have a completely normal echo and then I see a plump IVC, I'm going to look a little bit more for like a pneumothorax or tamponade, right? So it kind of like just changes based off of what I see. And then I don't always go all the way down to the P. I don't know. Is that wrong? Do you think I should always go down to the P even if I like diagnose heart failure, for instance?
No, I think you're right. I mean, I've done the same thing. I have the diagnosis. I kind of get focused on it. I think that's natural. But yeah, I can't say I always do it, especially if like I need to do something after I see that finding. I'm definitely not always doing the pulmonary aspect. I would have to say. I don't think I see that many pneumothoraxes where they're super unstable. It's also not that common. But again, going back to like, yeah, you should get in the habit of doing an algorithmic approach, but totally agree. When I'm doing and I see that diagnosis, then I'm going to usually act on it or probably cut the exam short. The other thing I like about it though is sometimes it's actually not even part of the high map, and while I'm doing the scan, I find something I was not expecting, and it makes the diagnosis. So I had a case where they were shocked And then we saw that they had mitral valve endocarditis. We just
Wow.
saw the vegetation. So
Yeah.
a lot of times, you're doing the application for one thing and you see something else, and right, you can't unsee it, right? You
Right.
saw
Which is
the
good. You don't
diagnosis.
want to unsee it.
I don't want to unsee it, but you know what I mean? Like
Yeah.
it kind of moves you forward, and sometimes it's by accident.
Yeah.
So it's kind of like just doing that further investigation may end up giving you the answer you need, even though you didn't intentionally look for it,
That's okay.
but you found it. So I just think it's such a high yield exam, and I think fairly straightforward for identifying like significant pathologies. So I'd love to see that continue to be integrated into community medicine practice, community ER practice.
I love it. That's such good insight. I think let's go ahead and end there. I have more questions, and maybe we can do a part 4 at a bit different time. I do also want to do some image review with you at some point in the future, especially like our first episode we talked about advancing the pacer under ultrasound guidance. We got some cool clips of those. So we'll talk about that in the next time. But in the meantime, check out our first and second episodes of the podcast on the YouTube and on the website. And Mike, thanks so much for stopping by, and can't wait to see you in person and chat more.
Yeah, thanks for having me. Appreciate it.
Of course.
Take care.
I hope you enjoyed that as much as I did. If you want to learn more about what Dr. Macias does in his spare time, well, it's him and Dr. Matt Recenti, who's also a good friend. Check out thePOCUSAtlas.com. If you want to learn more about what we do at Core Ultrasound, you can go to coreultrasound.com. If you'd like to check out some of our courses, including our 3,200 question bank, check out courses.coreultrasound.com. Make sure that you check out ultrasoundleadershipacademy.com if you want that more thorough education. And we have a sister site, ultrasoundgel.com. I'm actually on that podcast as well, and we do an amazing job at literature reviews on there with regards to specific articles. So check out ultrasoundgel.org. I hope to hear from you soon, and happy scanning.